Good morning. Thanks for having me. I am Guillaume Castel. I'm the CEO of PerfectServe. Disclaimer up front, I am absolutely not a health equity expert, but I'll tell you how we believe we have an impact on the topic nonetheless. So what is PerfectServe? We are a software company that provides services to mostly health systems and physician groups around the United States. We work with about 120 health systems, more than 600 hospitals, and probably in excess of 10,000 physician groups now around the US. And we have one goal, and our goal is to accelerate speed to care and improve the engagement between patients and clinicians. As I spend time with our clients, they tend to force me to focus on three things. First is to bring joy back to caregivers. It's been hard for caregivers in the last few years, particularly since the beginning of the COVID crisis. Second is to help them strategize around how to retain caregivers. The Great Resignation that is impacting all industries has had a massive impact on the healthcare industry. And then last but certainly not least, and very relevant to the discussion we're having today, helping them get smarter on engaging and connecting with patients more effectively. And for us to do that the right way, we've spent a ton of time thinking about how to build new products and solutions with equity in mind. So I'm going to spend the next few minutes telling you about how we think about equity as we build new products, particularly software products. So as a company, we had to get smart and learn about the problems, right? And so we did some research, and what we have tended to rally around are a few facts that are very relevant to me personally and to our company more broadly. One, over the last decade, infant mortality rates have been 2 to 3 times higher amongst the Black population in the United States. Two, in a study we did with one of our clients in the Northeast, emergency room wait times are 4 times higher when English is not your first language. Three, disparities and inequities cost our overall economy about $300 billion a year. Four, the annual average health expenditure is about $1,800 higher for food insecure adults than the normal population. So we've taken those things to heart. We've spent a ton of time thinking about how we could build products that actually had an impact on this. And because we serve primarily the provider space, which are hospitals and physicians, but also health plans and to a lesser extent the government, it's really forced us to think about ways to have an impact. So first, I'm going to tell you about our products. We've spent time with stakeholders, and we realize with a great deal of transparency that we're not going to have a profound impact on what's now commonly known and accepted as the social determinants of health. And yet our clients are expecting us to play a role. So we focus on building products that foster better coordination and engagement. So what does coordination mean to us? It means that clinicians inside of a health system, a hospital, a physician group, or the government are going to communicate more naturally, that the messages will get to the right person at the right time, that care is going to be more seamless, that patients are going to have a better experience, regardless of who they are and where they're coming from, that standards will be adhered to. Increasingly, you have massive for-profit and non-for-profit health systems in the U.S. that have hospital presence in multiple states, sometimes even as many as 50 states. And we've noticed that care was being provided very differently depending on where the hospital was located. And we spent a ton of time wiring processes to ensure that care is uniform, that people can expect the same level of attention, whether they are being admitted in New Jersey or California. We've also spent a ton of time building products to focus on access for patients. What it means for us is that we're going to build tools to optimize scheduling for clinicians so that they know how to build their days most effectively. And that on the other side of that equation, we optimize the patient scheduling side so that people can be seen more effectively, right? We know that there is a massive problem about believing in having access to the health system. And we know that underprivileged populations tend to be seen in the emergency room when they could probably adhere to a more primary care form of care. We've also built tools to engage with patients where they're not in the hospital or in the care of a clinician. Increasingly, care is moving outside of the hospital, and for health system administrators, it's paramount to stay engaged with the patients regardless of where they are. And so we've got engagement tools that check on patients when they're home or just not in the hospital. And we've also learned through research that it was equally important to stay engaged with their families and their friends. It often play a very important role in making sure that people have come back for a health visit. People are actually adhering to their medications. So we do very serious engagements with the patients and also with their friends and families. And then last but not least, most recently, we've been spending a ton of time building capabilities around remote patient monitoring. And it is because we believe that this is a way to care for people where they are most comfortable in the most effective way. And this will continue to grow, I believe, in the United States and probably beyond. Less care in the hospital, more care at home probably leads to better care overall. So we believe that technology can play a big role in the way it builds products. I also spent a few minutes talking about who builds the products. And we believe that diversity amongst our ranks, whether they are engineers coding the products or strategy people thinking about what to build, matters. A bias in the engineering ranks leads to bad products. And so we spend time thinking about who should be on the team, why they should be on the team, what their perspectives are, what biases they may have. And we believe that healthy disagreement is good for that. For instance, a tool for a male surgeon in New York may look very different than a tool that is thought through for a nurse in Arkansas. And yet we have to build tools that all clinicians can use effectively. So we're spending time thinking through all those areas. And it's been a massive learning curve for all of us. What we know now is that we have to offer flexibility in how our patients are reached. Some patients like to be receiving text messages. Others still rely on normal phone calls. Emails work for others. And so if you're a health system trying to engage with your populations, you're going to have platforms that allow you to engage with the patients in the way they believe is most conducive to good engagement. We also have to assume that not all patients can download an app, right? So building products that maintain that level of engagement without forcing them to have the last version of an iPhone that downloads the best possible app on the App Store is absolutely necessary. And probably equally important, many patients in the U.S. now have become comfortable using portals, which require logins and a laptop and a number of other credentials. And the reality is that not everybody's ready for that, right? So when we think about building good products to help our clients actually connect with their patient populations, we take that into account. And we make sure that there are ways to communicate with patients that aren't going to download an app, that don't have an iPhone and don't have a laptop. So that's been massively interesting, very successful for us during the COVID crisis. We've learned a lot. We've done a lot for our clients. The last thing I'll say is we, even at PerfectServe, think about the patients and the populations a lot. But I must admit to you that our clinicians are exhausted, right? And we have to maintain a balance when we think about new products and new solutions between what is best for the patients and the populations and what is most productive, most conducive to effectiveness for our clinicians. They're burned out, they're underappreciated, and I think they need better tools to engage with their patient populations. So we've been spending time with health systems, but also, frankly, research institutions to try and find that balance.